turn it over now to Dr. Tran Minh, who's the lead of the WHO emergency response at Cox's Bazar. Welcome.
Thank you, Dr. Ward, and good day to all our participants of this webinar. Thank you for organizers to inviting WHO also to share our experience on this hepatitis C control effort in Cox's Bazar. May I have right to share my screen?
Yes, please go ahead.
Is my screen up?
Looks great.
All right, it's in the full screen.
Yes, exactly.
All right, so let's go. So indeed, so thank you for the previous speakers also to give some of the introduction to the subject, and indeed we need to acknowledge MSF who have been pioneering in this effort to control hepatitis C in the Rohingya population. So yes, my name is Tran Minh. I just joined WHO sub-office here just a month ago, but I think this is such a nice story that I would like to share with you, so that we are on. Yes, so on the page. So I would not spend too much of background, but just to emphasize that we have a huge population here. Nearly 1.2 million, and in this condition, the health system, but with multiple partners, a lot of humanitarian actors on the ground have provided from health posts to primary health centers, field hospital, field laboratories. I just would like to quote a little bit that Tanjira already mentioned about this administrative structure. So it's quite not complex, but it's actually multi-layered. As you see that we have in the top of Director General of Health Services of a Minister of Health. So this triple RC, we call that what we call the Refugee Relief Repatriation Commissioner. But on site, we have on the health side the district civil surgeon. So it's quite complex, different layer of administration, but the health sector is coordinated by WHO. So yes, it's arguably one of the most densely populated refugee setting globally. And in this kind of condition, as you have been described already previously, we have persistent transmission of epidemic-borne diseases with high burden, particularly TB, HIV in some extent, but extremely the hepatitis issue, not only C, but also B. But this is why in this kind of setting, we ask ourselves that what would be feasible, how to control some of these high burden communicable diseases. We're thinking that why, for instance, TB has remained too difficult to control, but hepatitis C, with the experience of MSF, has shown some potential on better control or even the elimination. These are where our starting point. I quote here very quickly only, it's already there's a few studies on the burden, and at the beginning MSF study was full, but now we have also some other studies that showing MSF say that some 85,000, or we could say that 95,000 of active cases estimated. So this is a substantial public health burden, and as we know that it's not only on end stage of hepatitis C, meaning the liver malfunction, even cirrhosis or hepatocellular carcinoma. But the example of patients show that fatigue and functional, general condition will drop quite dramatically with the hepatitis C. So you can say that the burden of disease is substantial. So far we have what we have faced is the challenge that has been the whole service delivery has been like very much disrupted due to, of course, not all partners on the ground. I see that the 49 partners on the ground delivering. So not all were able to let's say provide such seamless from detecting of cases to giving confirmatory tests and linked to care, in particular the care session is what is very much the critical question, not only that detecting those cases, but how to provide those the regime of this 3 months or 6 months of care. So this is our challenge, but how we see that we could do is, I mean, with partners that we can accelerate. We say that high level of control, but vision is that global elimination of hepatitis C by 2030, that WHO launched that initiative. And this was based on a number of factors. Actually, we are thinking that some of the key elements here. So first of integrated care and how to rapidly to link it from screening to treatment, as well as we need to have a system in place to monitor, meaning the surveillance from the symptomatic to the surveillance of after that, how to referral for different point of services that I will help later on. So some of these thinking need to be behind how the response model would be shaping up. Here we have the map, as you see, of first on the left panel, you can see that how many of surveillance sites from the 17 hub to 24 sentinel center. And on the right panel, you can see how many of treatment centers that now 9 is what run under WHO coordination, but MSF just mentioned that they have 3 more treatment sites as well. So from screening to diagnosis, all these treatment pathways in coordinated manner with, of course, the government authorities as well as the partners. Here, like a treatment cascade, I just say that from when the patient walk into a health post or primary health center, up to screening, up to go to sentinel site to have sample collected, and after that confirmation if it's now confirmatory test is positive. So how we can refer to treatment centers and afterwards a follow up. So as you see that this is what we see that is put like a seamless flow from screening to treatment. Now, so the burden is enormous, but how we can think to scale up this. So first we have this established what we call Hepatitis C Technical Task Force, and we have been developing the guideline. This now has been finalized. We're going to launch in a week or so the new guidelines for hepatitis C. And we have also to monitor that we have the real-time monitoring dashboard, as well as we are starting to think that how that MSF already has initiated some like community-based, I mean, or door-to-door way to reach those not only that the patient seek help in our facilities. So we have trained more than 400 now of the healthcare workers to that, and with support of the partners, donors, we have been able to procure quite a number of rapid diagnostic tests, PCR reagents, as well as drugs. Now, what the current situation looks like. We have been to screen more than 100,000 individuals, and that's not surprising. Among pregnant women, the prevalence has been, like in previous studies, is high. So treatment coverage, we have now reached something like estimated 22% of estimated total burden. I mentioned in the beginning, the 95,000. So we still way to go, but still this has been quite achievement so far, past since now 24, now 26, 2 years. The cure rate, the viral cure rate is at 12 weeks is 94%. As well as the short from screen, I think relative short, I would say, from screening, confirmatory tests, as well as start of treatment is less than 2 weeks. And lots to follow up, same figures that MSF already quoted. So I would consider this kind of setting, lots to follow up is very much commendable. So one of the questions we say that in this kind of densely populated, I mean population, and also some newcomers, and they movement of the Rohingyas. So how about the compliance? How we can ensure that that we can have good compliance in our program. So here are some of the enablers listed there, from coordination work to integrated care cascade. Link is from mentioned already, from the screening to treatment. We have this early warning system to track the surveillance, and of course from the side that we say that we have treatment duration is definitely shorter than if you compare with tuberculosis or other chronic diseases or communicable diseases, and it's quite tolerated, the drugs, and we have very clear endpoints how to achieve. So this is some of the enablers how our program would be, possible in this context. We do have challenges, and I think that mentioning here only a few quickly, that the disease burden is enormous, right? And unless we have enough speed up our efforts, so maybe the transmission will continue in community without response effort. We have no how about reinfection that we have not looked at, but these are some of the challenges, and it's costly. We know a partner are with us, but whether we do have some level of partner fatigue, donor fatigue, so that whether we are able to sustain this effort. But the most critical thing that how the national system would be integrated. Of course, in Bangladesh host community, this is not a huge issue, but again, we need to have some system integration. All right, so a few snapshot of what we already mentioned, that how we say that elimination will be feasible in humanitarian setting, coordination effort, integrated service delivery, linkage from screening to care, and then we need to assure our continuous supply chains, and this is really the community are with us, so we are able to let's have a high level of compliance as well as participation. This is a kind of proof of concept so far. We have a way to go, but I do believe that that with this experience, we are confident that continuing this effort jointly with partners, we are able to achieve. So my very last slide, I take the title that we need to continue to raise awareness, like this seminar, as well as mobilize resources. But I have some specific here listed, some of these considerations, how we can eliminate, follow follow through our elimination effort. But we say about the financing of diagnosis treatment, community-based screening, we mentioned that, and how we can scale integrated across all services, like preventive mother-child transmission, other hepatitis diseases connected to like HIV screening or syphilis screening in the MCH clinics. I mentioned already how to strengthen national ownership and system integration, and then some long-term financing policy alignment, as well as partnership and collaboration. I cannot, thank enough that we have partner engagement. Very strong lineup here on my last slide. As you see that from the UN partners on the first, of course, the ministry and health sector, UN partners, a long list of implementing partners, as well as donors, all are captured there, hopefully in this slide to acknowledge them. So let me thank you for your attention, and over to you, John.
Thank you so much, Dr. Tran.